In patients with massive hemothorax, the neck veins may be flat due to severe hypovolemia, or they may be distended if there is an associated tension pneumothorax. This condition is suggested when shock is associated with the absence of breath sounds or dullness to percussion on one side of the chest. Massive hemothorax is initially managed by simultaneously restoring blood volume and decompressing the chest cavity. After placement of chest tube, the immediate return of 1500 cc or more of blood or continued bleeding generally indicate the need for urgent thoracotomy. During patient resuscitation, the volume of blood initially drained from the chest tube and the rate of continuing blood loss must be factored into the amount of intravenous fluid required for replacement. The immediate return of 1500 milliliters or more of blood after chest tube placement generally indicates the need for urgent thoracotomy. Patients who have an initial output of less than 1500 milliliters of fluid but continue to significantly bleed may also require thoracotomy. In addition, the persistent need for blood transfusion is an indication for thoracotomy. Penetrating anterior chest wounds medial to the nipple line, potential injury to the heart and great vessels, and posterior wounds medial to the scapula, referred to as the mediastinal box, should alert the practitioner to the possible need for thoracotomy. Cardiac tamponade is compression of the heart by an accumulation of fluid in the pericardial sac. This results in decreased cardiac output due to decreased inflow to the heart. This condition most commonly results from penetrating injuries, although blunt injury also can cause the pericardium to fill with blood from the heart, great vessels, or epicardial vessels. Cardiac tamponade can develop slowly, allowing for a less urgent evaluation, or rapidly, requiring rapid diagnosis and treatment. The classic clinical triad of muffled heart sounds, hypotension, and distended veins is not uniformly present with cardiac tamponade. Kussmaul's sign, a rise in venous pressure with inspiration when breathing spontaneously, is a true paradoxical venous pressure abnormality that is associated with tamponade. Pulseless electrical activity is suggestive of cardiac tamponade but can have other causes. Tension pneumothorax, particularly on the left side, can mimic cardiac tamponade. The presence of bilateral breath sounds indicates cardiac tamponade versus tension pneumothorax. FAST is a rapid and accurate method of imaging the heart and pericardium that can effectively identify cardiac tamponade. Tamponade can develop at any time during the resuscitation phase, so repeat FAST exams may be necessary. Echocardiography and/or pericardial window also can be useful in diagnosing cardiac tamponade. When pericardial fluid or tamponade is diagnosed, emergency thoracotomy or sternotomy should be performed by a qualified surgeon as soon as possible. Administration of IV fluid may raise the patient's venous pressure and improve cardiac output while preparations are made for surgery. Pericardiocentesis is a temporizing, life-saving measure of last resort in a setting where no qualified surgeon is available to provide definitive care.
Start by viewing the heart using the subxiphoid or the parasternal view. Fluid within the heart should appear black. The presence of fluid outside the heart within the pericardial sac is abnormal and is consistent with pericardial tamponade.
Trauma patients who are unconscious and have no pulse, including pulseless electrical activity, as seen with extreme hypovolemia, ventricular fibrillation, and asystole, are considered to be in circulatory arrest. Causes of traumatic circulatory arrest include severe hypoxia, tension pneumothorax, profound hypovolemia, cardiac tamponade, cardiac herniation, and severe myocardial contusion. In these patients, it is important to consider the possibility that a cardiac event may have preceded the traumatic event. Circulatory arrest is diagnosed according to clinical findings. That is, the patient is unconscious and has no pulse. This condition requires immediate action. Do not delay treatment to perform diagnostic adjuncts. Start closed CPR simultaneously with ABC management. To alleviate a potential tension pneumothorax, perform bilateral finger or tube thoracostomies. Continuously monitor ECG and oxygen saturation and begin rapid fluid resuscitation. Administer epinephrine, and if ventricular fibrillation is present, treat it according to advanced cardiac life support protocols. According to local policy and the availability of a skilled surgical team, a resuscitative thoracotomy may be required if there is no return of spontaneous circulation. If no surgeon is available, and a cardiac tamponade has been diagnosed or is highly suspected, a decompressive needle pericardiocentesis may be performed. Do not perform thoracotomy unless a surgeon qualified by training and experience is present. Patients with thoracic trauma involves further in-depth physical examination, ongoing electrocardiography and pulse oximetry monitoring, arterial blood gas measurements, upright chest X-ray in patients without suspected spinal column instability, and chest CT scan in patients with suspected aortic or spinal injury. To lung expansion and the presence of fluid, the chest X-ray should be reviewed for widening of the mediastinum, a shift of the midline, and loss of anatomic detail. Multiple rib fractures and fractures of the first or second ribs suggest that a significant force was delivered to the chest and underlying tissues. Unlike immediately life-threatening conditions that are recognized during the primary survey, other potentially lethal injuries are often not obvious on initial physical examination. Diagnosis requires a high index of suspicion and appropriate use of adjunctive studies. If overlooked, these injuries can lead to increased complications or death. These are the potentially life-threatening thoracic injuries that should be identified and managed during the secondary survey. Each is described in this module. Pneumothorax results from air entering the potential space between the visceral and parietal pleura. Air in the pleural space disrupts the cohesive forces between the visceral and parietal pleura, allowing the lung to collapse. A ventilation perfusion defect occurs because the blood that perfuses the non-ventilated area is not oxygenated. Both penetrating and non-penetrating trauma can cause this injury. Lung laceration with air leakage is the most common cause of pneumothorax from blunt trauma. Perform a comprehensive physical examination of the chest, including inspection for bruising, lacerations, and contusions. Assess movement of the chest wall and assess and compare breath sounds bilaterally. Percussion may demonstrate hyperresonance. When a pneumothorax is present, breath sounds are often decreased on the affected side. An upright expiratory chest X-ray aids in the diagnosis. Patients with blunt polytrauma are not candidates for this evaluation, although patients with penetrating chest trauma may be. Any pneumothorax is best treated with a chest tube placed in the fifth intercostal space, just anterior to the midaxillary line. After inserting a chest tube and connecting it to an underwater seal apparatus, with or without suction, a chest X-ray examination is done to confirm appropriate placement and re-expansion of the lung. A patient with a pneumothorax should also undergo chest decompression before transport via air ambulance due to the possible expansion of the pneumothorax at altitude. A hemothorax is a type of pleural effusion in which blood accumulates in the pleural cavity. This condition is typically caused by laceration of the lung, an intercostal vessel, or an internal mammary artery from penetrating or blunt trauma. Thoracic spine fractures may also be associated with a hemothorax. Expose the chest and cervical areas and observe the movement of the chest wall. Look for any penetrating chest wall injuries, including the posterior thorax. Assess and compare breath sounds in both hemothoraces. Typically, dullness to percussion is heard on the affected side. Obtain a chest X-ray with the patient in the supined position. A small amount of blood will be identified as a homogeneous opacity on the affected side. An acute hemothorax, large enough to appear on a chest X-ray, may be treated with a 28 to 32 French chest tube. The chest tube evacuates blood, reduces the risk of a clotted hemothorax, and allows for continuous monitoring of blood loss. Greater than 1,500 milliliters of blood obtained immediately through the chest tube indicates a massive hemothorax that may require operative intervention. Also, if drainage of more than 200 milliliters per hour for 2 to 4 hours occurs, or if blood transfusion is required, the trauma team should consider operative exploration. A flail chest occurs when a segment of the chest wall does not have bony continuity with the rest of the thoracic cage. This condition usually results from trauma associated with multiple rib fractures, although it can also occur when there is a costochondral separation of a single rib from the thorax. Pulmonary contusions develop when blood and other fluids accumulate in the lung tissue following thoracic trauma. This interferes with ventilation and potentially leads to hypoxia. Pulmonary contusion can occur without rib fractures or flail chest, particularly in young patients without completely ossified ribs. In adults, this condition is most often encountered with rib fractures. The resultant respiratory failure can be subtle, developing over time. Abnormal chest wall movement may be observed, although several factors may impede visualization of this finding. If the injury results in significant underlying pulmonary contusion, serious hypoxia can result. Restricted chest wall movement associated with pain and underlying lung contusion can lead to respiratory failure. Observation of abnormal respiratory motion and palpation of crepitus from rib or cartilage fractures can aid the diagnosis. A chest X-ray may suggest multiple rib fractures, but may not show costochondral separation.